just few comments as to just the last few talks. One is about vertebroplasties. I think that we do them here a lot, and typically I don't even put both needles on both sides. If you can cross the midline on an AP with the unilateral needle placement, very commonly both sides of the vertebral bodies are going to be filled in very nicely just with one needle placement. So that cuts down on the length of the surgery, that cuts down on the amount of radiation that you need to use in order to place the other needle. So you can put one needle through the pedicle, make sure that you cross the midline or reach the midline with one needle, and then typically we inject, and if we get bilateral field, that's all it's needed. And if it looks like you get unilateral field, then you can always drop the needle on the other side. So most of the time we don't find it necessary to place two needles, and it makes the surgery much shorter, especially if you have to do multi-level injections in multiple broken vertebrae. I think it's very important to monitor and be careful as you inject the cement. And once you reach the posterior 1/3, you got to be very careful to make sure the cement doesn't leak into the canal. So typically we do it again under both AP and lateral fluoroscopy. And once we reach the posterior 1/3, we typically stop with the injection. There are a multitude of cement options when it comes to very liquidy type cement or very much more thick cement. And sometimes we have to make a decision before the cement injection whether we want to use a thick or more of a liquidy type cement. Remember that time is in essence, as you continue with the procedure and you have multiple levels, the cement gets harder and harder. As to radiofrequency ablation options, this is an option, though we typically follow a lot of these patients with radiosurgery. And so sometimes whether you need ablation or not, it depends on the institution that you are. If you don't have a radiosurgery option, that could be an option. Cavity creation, whether you do it through kyphoplasty or whether you use a curved needle, it has advantages and disadvantages. When you create a cavity, the cement clearly would want to go there, but sometimes there's a benefit for the cement interdigitate actually with the bone and becomes one with it. Sometimes when I have to go through removing cement, do a vertebrectomy on a vertebrae that already had cement in there, and if this was a kyphoplasty, we see sometimes that the ball of the cement is just sitting there and can turn around and really doesn't engage the bone itself. It's just like a big plug of bone sitting there. So sometimes interdigitation with the bone is beneficial. As to the talk with the neurology, neuro-oncology, I think you guys are very fortunate to have somebody like that, because typically neuro-oncologists are more interested in brain tumors. They are very involved with the brain tumor, the neurosurgeons that do brain tumor surgeries. And to find a neuro-oncologist that have keen interest in spine and metastatic disease or en bloc resection and help coordinate a lot of the work that's done up front is a huge thing. And I'm curious to kind of know how your neuro-oncologist, a Swedish, found himself interested in that, because one of my struggles sometimes is with neuro-oncology, they're very focused on the brain component of neuro-oncology and not so much on the spine. And mostly because the spine is driven by the oncologists, the medical oncologists who are taking care of these patients. And clearly there's have to be a lot of coordination on these patients up front. So having a neuro-oncologist that's dedicated to that is a huge advantage. I'm going to give a quick talk about spinal instability here. It's already been mentioned here before. See if I can move this. So typically, we used to think about spinal instability from our trauma ward, and Jan is experts on the traumatic spinal injuries, but we used to have the Denise model of spinal instability with a 3-column model, and instability was defined if 2 columns are destroyed, then the spine by definition is unstable. There was also a 6-column injury by Pastwick or instability if 3 or 4 columns are destroyed. There's marked instability if greater than 4 columns are destroyed. Instability is sometimes defined as angulation greater than 20 degrees. And clearly, surgical approach and resection often increase instability. So we used to have models mostly coming from the trauma ward as to what define instability, and that ultimately led us to decide what type of surgery we should do. Should we do surgery or not do surgery? And initially, we thought about using those kind of models for patients with spine tumors, because clearly we wanted to know whether patients with lesions in the spine are stable or unstable. There were differences, though, between the traumatic injuries versus spine tumor, in the sense that spine tumor instability is more of a glacial type instability that evolves over a period of time, unlike the traumatic instabilities that are more instant, right? They occur in an instant. They are not logarithmic. They are not occurring over time. So we were not sure whether you can actually apply those type of models to patients with spine tumors. And then, with traumatic injuries, there's a lot of time association of ligamentous rupture, ligamentous injuries, and those things are not necessarily occur with patients with spine tumors. So there were differences in can we adapt the spinal instability models of trauma to the spinal instability models of patients with spine tumors. A lot of times when we're dealing with patients with spinal instability related to tumors, you don't necessarily have to have, algorithms or scales or anything like that to say this is unstable. As we do more and more of this type of surgery, sometimes all it takes is taking a look at an image and say, oh, this is unstable. You don't need an algorithm. You don't need a model. You can look at it and say this is an unstable spine. So clearly on this image where you're looking here, I'm not sure you need to look at any modeling or any algorithm to tell you whether this spine is stable or unstable. So when we as surgeons look at it, we can say very quickly that this is an unstable spine. But a lot of time it doesn't appear, it's not as obvious. And that's why we came up with this definitions. It's called the SIN score, the SINS score, where we try to define spinal instability in patients with spine tumors. And this is a very helpful diagram. I'm going to spend a little bit of time on it to kind of explain and figure out what this is all about. But you can see very quickly that it was very specific. So if you look at the location where the metastatic disease is, and I want to direct your attention to the fact that if you have a metastatic disease in a junctional area, occiput to C2, C7 to T2, T11 to L1, or L5S1, the patients immediately get 3 points. And the idea about this table is that you add the points, and ultimately if you have 0 to 6 points, this is a stable spine. If it's 7 to 12 points, it's potentially unstable. And if it's 13 to 18 points, then this is, by this table, is an unstable spine. And so going back to this table, location, junctional met, 3 points immediately. The second thing that I want to direct your attention to is pain. And you wouldn't think that pain is an issue when it comes to defining stability or instability, but it actually, in patients with spine tumor, it's a huge component. And it comes a second behind the location, but it gets just as many points. And you can see that we put a lot of emphasis on pain that is mechanical in nature, which means that the pain is getting worse with movement. The pain is getting worse when the patient's ambulating, sitting down. And in fact, we'd like to see pain that gets significantly better or disappear when the patient is lying down and not moving. So if a patient has relief with recumbency and or pain with movement, that means loading the spine, there is 3 points immediately right there. And so right there, just by looking at the top two, if you look at location and you have a patient with a T11, T12, or L1 lesion, and there is mechanical back pain symptomatology, the patient already got 6 points, and that's before even looking at the rest of the lesions. So right there, you're already at the top level of whether this is stable or unstable. And then the next thing that we look at is whether the lesion is lytic or not, because lytic lesion has more potential to break, unlike blastic lesions that have no potential of breaking. And you can see that for blastic lesions, we give it 0 points. And for lytic lesions, it gets 2 points, not as much as 3 points for mechanical pain or junctional lesion, but still a lytic lesion gets 2 points. And so you see that a CAT scan is very crucial in addition to the MRI and the other type of workup that you do to figure out and look to see whether we're talking about lytic lesion or whether we talk about a mixed lesion or whether we talk about plastic lesion, because those are the type of points that's going to be added to the overall score. The next thing that we look at, and that's where you get the most point, is that you look at radiographic spinal alignment. And if there is any evidence for subluxation or there's any evidence for translation, then the patient immediately gets 4 points. These are clearly things that point to a high level of instability, and as such, evidence for subluxation or translation get the most amount of points on this SIN score, which is 4 points. And then the next thing is going to be vertebral body collapse. If it's more than 50% collapse, then the patient gets 3 points. If it's less than 50% collapse, 2 points. If there is no collapse, with about more than 50% body involvement, it's 1 point. And if there is no collapse, 0 points. And then the last thing is the posterior elements. And whether there is a posterolateral involvement, what I mean by that is pedicles, facet, a costovertebral junction. And then if there is significant posterolateral involvement with bilateral involvement of both facets, both pedicles, 3 points. If it's only unilateral involvement, it's 1 point. And if there is no involvement whatsoever, then there's no points given. And so as you start adding these points up, you can apply these to any metastatic disease in the spine. And then once you add these points, you can figure out whether this is a stable lesion with a 0 to 6 points, whether this is potentially unstable lesion with a 7 to 12 points, or whether this is unstable lesion, and that's going to be 13 to 18 points. And a lot of time, as I mentioned, sometimes all it takes is to look at the image, and if we are experienced enough to say, I know this is unstable, but I would say keep kind of adding those points and kind of make sure that what you think that it looks like based on looking at it is actually matched with this scoring system. So here is one of those that initially when you look at it, you say, well, this is a stable lesion. I mean, it's just kind of involving a little bit of the vertebral body. Not sure this is really stable and unstable, maybe stable. But this is a 66-year-old gentleman. He has lung cancer with metastatic disease to L3, and he has lower back pain. But what's kind of key right there to an issue here is that it works with activity, which gives you immediately the thought that this is mechanical in nature, because sometimes it's a biologic pain. Sometimes it's pain that comes from just tumor within the bone that causes pain. And typically, if there's no fracture there, these are the kind of lesions that may respond to chemotherapy, may respond to radiation, not necessarily needs to have a vertebrectomy. But here you got a patient who has pain with activity. And as I already emphasized before, when you have pain with activity, it points to a mechanical pain. And in this particular case, if you look carefully, you see that there's actually a fracture in this vertebra. And if there is a fracture in that vertebra, then your suspicion for mechanical back pain symptomatology goes up. The patient is neurologically intact. He has no radiculopathy, but he does have pain with movement, points toward mechanical pain, and likely related to the fracture at L3. So we're going back to our table here, and as we start going through this particular lesion, it is in a mobile spine. It's at L3, so it gets 2 points for it. It's not junctional. It's not a thoracic spine. It is at L3, so it gets 2 points for that. The second question, does he have pain with movement, mechanical pain? And the answer is yes. And so the patient gets 3 points for that. Is the lesion lytic, mixed, or plastic? And for that point, it was lytic on the CT scan, so he gets 2 points for that. Is there any misalignment? And the answer is no. There is no subluxation. There is no translation. There is no deformity. And so in that sense, the alignment is normal. It gets 0 point for that. Vertebral body, is it more than 50%? Is it less than 50%? And the answer here, it was less than 50%, probably about 20% collapse of the vertebral body, so it gets 2 points for that. And is there posterolateral involvement? And for this patient, it was only involving the vertebral body, and so the patient gets 0 points for that. And so if you look at that, on the SIN scores, the answer is 9. And what the total amount of points is 9, which means this is potentially unstable. So what does it mean? Does it mean that the patient needs surgery? Does it mean that the patient doesn't need surgery? That is not what this table is about. This table does not tells you whether patients need surgery or don't need surgery. It just gives you an insight about the potential stability or instability of the vertebrae. As to the decision whether the patient needs surgery or not surgery, I hope that through listening to all these talks from this morning, you realize that it's really a multidisciplinary discussion, with neuro-oncology, with medical oncology. What are the other options that are available for this patient? If it's a short life expectancy, maybe this is a patient who would benefit from vertebroplasty. If it's a long time life expectancy, maybe we should do a vertebrectomy here. Is it radiosensitive tumor? None of this stuff getting into this pure table that just tells you stability or instability or potentially unstable. And so it just gives you an insight as to the stability, but it doesn't give you any recommendation as to whether the patient needs surgery or doesn't need surgery. So this is kind of like a brief look into stabilizations of patients and whether the metastatic lesions are consistent with instability or not. The other component of my talk in the last 2 minutes is that I was asked to give a talk is just kind of instrumentation on patients with spine tumors. And again, I wanted to just give you my one slide that I think is very important. What are my indications for surgery? And then how do we stabilize this patient when it comes to instrumentation? And the 4 criteria really, to make it a very simple 4 points, is really when do we do this type of surgery? We do it when we try to alter prognosis, maybe extend life expectancy, especially on patients with unblocked resections for primary bone tumors. But number 2, you see that that's one of the indications for surgery. It's whether the spine is stable or unstable. If there's evidence for spinal instability or deformity, these are one of the indications for surgical treatment. The 3rd criteria would be neurological compromise. And the 4th criteria would be, again, intractable pain. Pain is a very strong component of whether patients need surgery or not. I've mentioned this before, again, alter prognosis. And when it comes to our surgeries, these are the options that are already have been discussed when it comes to intralesional, unblocked resections, stereotactic radiosurgery, or vertebroplasty, kyphoplasty. I'm going to go through this quickly. These are the intralesional resections, and you guys are all familiar with that, where you're going in, you can do a vertebrectomy. Anterior approach is a very gentlemanly way. This is a single met just with an anterior pathology. And in these type of cases where you don't think you're going to need to go in the back, it's very nice to be able to go just from the front and do a surgery through the chest or through the thoracolumbar region and get the ligament off. You can even do a decompression of the nerve roots from the front, and then you can really come in and once you do the vertebrectomy, you can reconstruct it. This used to be the old Canada device, and then I put a carbon fiber cage there, and you can see bicortical screws. And a lot of time, that's all that's required. And you can see on this picture right here where the pedicle has been removed, you can identify the lateral edge of the dura. And by doing that, be able to remove the ligament, put your cage in. You can even go to the contralateral size and drill some of the contralateral pedicle for purpose of reconstruction. And typically for a single level disease, that's all that's needed. You don't need to do anything else. In this particular case, with an anterior column support, within a couple of weeks later, this patient developed significant recurrence. And so clearly, you got to be able to think about posterior construct reconstructions and supplement this whenever it's needed. And that's what it looks like at the end here. When it comes to those intralesional resection, there are a lot of cages options, as Rod have mentioned, when it comes to what are the options to place there. But all these anterior approaches are very nice ways of being able to reconstruct the anterior columns. Vertebroplasty, kyphoplasty are also mechanical instability options when the patient's prognosis is very poor and they are not candidate for big surgeries. So a lot of these options are available for surgeons to be able to use this type of treatment options for patients who are not good candidate for a conventional surgery but have significant amount of mechanical back pain. There are some limitations sometimes. There's some contraindication. You gotta entertain all these options. And the idea ultimately is you do not want cement to leak into the canal, especially when you have bad fractures, bone in the canal. And sometimes those are the cases that happen. You got to scrutinize the CAT scan to watch for the posterior wall to make sure that whether there's breakage in the posterior wall that increase the risk of cement leaking into the canal. So you really want to watch for those type of things so that they do not happen. This is sometimes what can happen. You can see cement leakage right here into the foramina. Here is a situation where a lot of cement was injected very rapidly, and you can see cement actually in the canal. So, this is multiple pulmonary cement particles. Sometimes you can find cements also in the brain. So here is a case where you can see there was absence of the posterior wall, and once you inject cement in there, that cement have no problem leak itself right into the canal itself. Vertebroplasty options can be very nice ways of sometimes even take it further. This is a patient with a big lytic lesion in the odontoid or in the C2 vertebra with mechanical neck pain. Typically, we used to do OC fusions for these patients to stabilize the spine. But, with careful analysis, there are options of doing even a transoral vertebroplasties for these cases, and stay away sometimes from doing, these type of surgeries where you go in and you do a big occipital cervical fixation. So a lot of these cases, you got to evaluate for the technical feasibility of what exactly you want to do. I showed this slide before. A lot of these cases require for you to be facile with all kind of approach to the spine. This is a common procedure that we do with a transpedicular vertebrectomy. This is a T3, T4 met, where you can go in from the back. You can do a lot of the vertebrectomy to the back end and do the entire vertebrectomy, ligate the nerve roots, and then able to reconstruct the anterior column through a posterior approach. In addition to a transpedicular approach, at times you may need to do a transmanubrial approach or transsternal approach, especially at the T2, T1 area. You got to sometimes split the chest open. So I'm just showing some of these slides to show that when you're dealing with patients with spine tumors, it is multidisciplinary, and you got to be facile with all kind of approaches. In our lab right now, in our cancer engineering program, we're looking at all kind of things right now with 3D printing, predicting vertebral body fractures, when they're going to break, when they're not going to break. And we're creating a lot of 3D modeling of patient-specific modeling for patients with tumor. This is a patient with breast cancer, and we can create modeling of the fracture. These modeling can help us decide, do we need to go 2 levels above, 1 level above, 3 levels above and below. These models are very specific for this type of patients. And we're looking at some custom spine implants in our lab right now, especially for an en bloc resection, where we can create model-specific 3D printers for this type of patients. So in conclusion, the management is challenging. We can restore and protect neurological function. We can improve pain. And these cases, when you pick the patient and select them appropriately, can have significant impact on the quality of life of this patient. I want to stress again that the biology, the type of tumor is critical in defining the goal in these patients. And surgeons dealing with this type of tumors have to be familiar, as Rad showed so many times in his labs. You got to be familiar with the various surgical approaches, as well as the anterior-posterior constructions technique in order to provide optimal care for these patients. Thank you.
Well, thank you very much. That's a great talk, and I think a really good discussion, because the SIN score is one of those scores that we can find in the literature, and we help it to guide us with surgery, but so much of doing a tumor surgery is really discussing with the patient and their goals, and I really appreciate you talking about that. Does anyone have any questions from the group? I just, one of the things that I bring up, obviously something like a sacrectomy, you really need a lot of fixation to, there's just a huge gap there to restore stability. How much does the type, sometimes we have widely metastatic disease, maybe there's one one area of compression in the spine, but there's multiple other areas where there is tumor. How much does that factor into your construct and how you're gonna go ahead with that surgery?
Yes, I think that's what we mentioned earlier, that trans-screw vertebroplasty fixation is huge now. And if a patient ultimately clears, when you say metastatic disease in multiple levels, is the patient really a candidate for surgery? We weigh the vertebroplasty option very heavily, especially when there is mechanical back pain symptomatology, especially when there is no cord compression. If the patient's prognosis is not great, but they have significant mechanical back pain symptomatology, we highly would consider doing vertebroplasty followed by even radiosurgery or conventional radiation. If it's somebody who has reasonable life prognosis, life expectancy, and there is cord compression that requires some surgical intervention, then we'll supplement all these screws with the cement through the screws themselves. So I think, as I mentioned earlier, the trans-screw cement injection revolutionize our options for this patient. It requires really scrutinizing the CT scan. Are they, again, there could be lots of mets, but are they plastic or lytic? I mean, if they are plastic lesions, these are likely will not break any further. In fact, sometimes it's hard to get the screws through these plastic lesions because they are hard as a rock. But if they are lytic, then there is an option for placements of screws with the cement injected directly through the screws.
Yeah, I know I found that to be a very good option in my practice as well. So really appreciate the talk. Thank you.